So this is Aliyah Baluch. I'm podcasting the presentation, the James A. Haley VA IM ID Noon Lecture 3 Case Studies to introduce epidemiological-based infections in hematopoietic cell transplant patients. The goals and objectives is to understand geographically based infections and updated warnings from the state of Florida. As always, as a member of stewardship at my facility, the subject matter is supported by the SMART. So, case number 1. Ms. M.W., it's just random letters for the initials, is a 31-year-old with past medical significance for a megakaryocytic thrombocytopenia status post a match-related donor stem cell transplant back in 2018. Presents with fevers. No localizing symptoms. Cultures were taken, empirically placed on cefepime and daptomycin. The patient had been on dapto at home for approximately a week and a half for a recent staph epidermidis bacteremia. This is just to show what was happening. What kind of made this case really interesting was, as you can see, multiple fevers without an apparent type of pattern, just every single day, multiple times per day, and high, not necessarily low at all. So the patient had hematuria while with borderline count. So what would you do? What would you order? So a urine analysis with microscopy, a urine culture. So here was a urine analysis. It has moderate blood, has some small amount of leukocyte esterase, which is definitely infectious looking because it's got 11 to 20 WBCs, but there are more than 20 squames. So maybe a bad sample, you would consider asking the patient to get another sample. Because the patient is a transplant recipient, we did look at for hematuria, is this from BK or is this adenovirus? So we checked BK, it was definitely negative, urine, negative blood. And there's your adeno that we ordered, and it was also negative. So at least in terms of hematuria, it wasn't like the two baddies that it could be. Usually not quite this far out from transplant, but doing due diligence, we did look at both of them. So then it came back to what we initially saw, this FUO or fever of unknown origin. What the heck is going on that this patient is having so many fevers? So she denies travel, denies any new medications other than daptomycin, which started about 3 to 5 days prior to the fever. So could, but not necessarily, because with the T1/2, the fever would have come faster if it was related to the daptomycin. She denies any sick contacts, denies any new rashes, and essentially denies everything else other than the fevers in the recent visit to us in the hospital. So in terms of the transaminitis, what type of workup would you do? We did check a hepatitis A because there's an ongoing outbreak in the state of Florida as well as specifically Hillsborough County. And it was A, but we talked to her further and it looked like she maybe had been vaccinated in the past. You can see the hepatitis A IgM is negative, so it's definitely not an acute hepatitis A. We also checked hepatitis B, which you could see core is negative, surface antigen is negative. We were double checking because she had a history of being a cleared hepatitis B infection in the past, so that's why we checked in that as well. We did check a hepatitis C because, she is a transplant recipient. She has received blood products before. With the recent bacteremia, we did a 2D echo with her kind of abnormal baseline labs for someone who's this far out from an allo transplant. We did actually also do a bone marrow biopsy. We did also a hemophagocytic syndrome workup or HLH workup. But to be honest, the trigs were just minorly elevated, as was the ferritin, but it was not like screaming HLH as a whole. The bone marrow biopsy workup for an ID workup, you have to remember, obviously you still do the pathological because, does she now have a cancer? In terms of the ID workup, it's like a liver or a lung biopsy that half the sample goes to path, half the sample goes to micro. We look at the bacterial stuff, fungal stuff, AFB being acid-fast bacilli. And then we try to make sure we're not missing anything else. So just as a quick side moment here, we'll talk about pneumocystis prophylaxis, that if you're trying to prevent pneumocystis, the drug of choice is Bactrim. And then it also covers for toxo, just like atovaquone, but if you use dapsone or inhaled pentamidine, you only get the PCP coverage. Well, for our particular patient, before we were going back to the case, there's just two other caveats. With dapsone, you have to order first a G6PD, and that for inhaled pentamidine, please make sure that you are not hitting one of the contraindications, being patient has asthma, patient has bronchospasms, reactive airway, or let's be honest, if they have active pneumonia, that's not a good drug to use. If they have a huge pleural effusion, that's not your drug to use. So she actually was toxo positive at the time of the transplant. We're like, okay, so is she on the best, prophylaxis? But she had actually somehow gotten flipped over to inhaled pentamidine. If you can remember from the prior slide, inhaled pentamidine doesn't actually cover toxo. So there must have been a point in time that someone just was like, well, she has bad counts, so we're going to flip her to inhaled pentam without double checking her toxo status. So before we were able to just put her on preventative therapy that would be for PCP and toxo, you actually have to rule out acute toxo. So by doing that, we did a toxo blood PCR. It was thankfully negative. In terms of having poor counts in a patient post-transplant, we also did test for toxo with a bone marrow just to make sure that we weren't, overlooking anything, essentially leaving no rock unturned. Thankfully, those tests were both negative. Ongoing workup for FUO, kind of going up that pyramid of unusual and rare issues. We were looking at HHV6 issues. Could she have enough to cause fevers as well as poor counts? She did have it detected, but it was not quantifiable, meaning it was very small amount. Shouldn't be what's driving this issue. Autoimmune issues. Does she somehow have culture negative endocarditis? So you can see here we did the workups for the immune as well as essentially culture negative endocarditis parts of it. We did also check for Lyme. Now this is where you start looking for super rare things, which honestly is probably not as rare as we think it is, because our patients get a lot of blood products. Blood products don't always come from the super local options, that some blood products could be coming from farther away, or the person who donated has just come back from a holiday, then donated, and then you've accidentally transmitted a rickettsial infection that then would only improve with empiric therapy or with appropriate therapy. So especially more so with RBCs, as I mentioned, you can pick up a rickettsial infection, very hard to prove. So this is where, after an exhaustive search for a variety of different infections, we just empirically put her on doxy, and then all of a sudden she defervesced. We did continue it for a full 14-day course, and then that was it. We were never actually able to fully prove that it was a rickettsial infection, but that was the pretest probability was enormously high because of how she improved on the drug of choice for rickettsial infection. Case number 2. Looking at the state of Florida, and then kind of concentrating down on Miami-Dade down in South Florida. So Mr. AB currently lives in the Miami-Dade area, had a transplant for acute myelogenous leukemia approximately a year ago, used to live in the Tampa Bay area, so that's why he still follows up with us. During his evaluation, incidentally noted some abnormalities on his vitals, and then his labs were drawn for the visit. So he had a fever, he was only mildly ill appearing, and as he's sitting there, he's starting to complain of body aches. During the physical exam, his fever started to escalate, he started to have a headache, but no photophobia. Maybe even though some nuchal rigidity, but negative Kernig and Brudensky signs during a rapid assessment. Of course, nobody likes their patient to be getting sicker in the middle of clinic. When we looked at labs, he previously had a normal neutrophil count, but it had dropped precipitously to neutrophils of 250, as did his platelets drop to 55, but still technically creatinine is normal, LFTs are normal. So if you have to look at a patient and say, here's an immunosuppressed patient in front of me with a febrile illness and a headache, this is a bad combination. You have to keep in mind, is this bacterial? Are there lines? Are there invasive devices? Are you just having a headache because you're having a wicked fever? Could this be fungal? Are you on steroids? Are you taking drugs? Could this be viral? Do you have any sick contacts at home? Do you have any respiratory symptoms that would help you lean towards one diagnosis or another? Could this be drug related? So we have a number of patients that have essentially repeated episodes of aseptic meningitis related to immunoglobulin infusions. Did we recently give you anything? Are you a drug abuser? Other? Always have to keep other. So in terms of workup, you would do your blood cultures, UA, urine culture, chest x-ray. You're going to do a stat CT because of this headache. Consider a lumbar puncture to rule out infection. Consider an MRI of the brain to rule out PRES, because after all, the patient is still on immunosuppression, and PRES is definitely within the differential diagnosis. What I'm trying to lean towards, though, because this patient is in South Florida, that there are definitely new issues popping up related to mosquito-borne infections. And so to compare and contrast dengue and chikungunya, that you should know which one has a higher fever is chikungunya, which one has shock is dengue, especially after having different types of dengue. Neutropenia is more often with dengue, as is thrombocytopenia, whereas lymphopenia is more a chikungunya issue. Arthritis is definitely a chikungunya, whereas severe arthralgia also chikungunya. Hemorrhage, though, goes back to dengue. Rash, chikungunya, and death, it goes with that whole shock issue for dengue, that this is a bigger problem and a higher risk for death. Travel, you want to ask the patient, has any time in the last 2 weeks have you traveled to an area where they have these infections? And the vector is the same for both infections, the Aedes mosquito. And then there was a really cool kind of graphic for comparing and contrasting chikungunya and dengue posted on the CDC website. And then it talks about the timing, about when you would have infection, when you could test for it, things like that. Where can you send these testing to? But the issue was this article, which was there was a locally acquired case of dengue in the Miami-Dade County that you have to be cognizant of. Interestingly, both the patients for this particular were that they were women, but one was 21, one was 66. But don't think that it's not here in the state of Florida. You do not have to travel outside the state of Florida in order, unfortunately, to get dengue. And this is, again, Miami-Dade County. Moving on to case number 3. So, clinic, Mr. SH is a 54-year-old past medical history sniffer AML. He's had his induction, 7+3, and he got it a second time. And then he got HIDAC, 1 and 2. He's pending his allo transplant, and he needs clearance due to some lung abnormalities. So you can see here, we did vital organ testing beautifully. We checked for EBV, hepatitis B, hepatitis C, HIV, RPR for syphilis, VZV, toxo, HSV, HTLV, and a different way for hep C. We also check an ABG, which looks pretty good. We check for CMV status, which he's like myself, he's CMV positive. We do imaging at baseline to be like, what do you have before we give you immunosuppression, before we give you more chemo? And as you can see, he's had chickenpox, he's had HSV before, he's had CMV before. And here comes the original problem. And as I was called, they're like, yeah, the patient is on ambisome, blah, 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 blah. I'm like, why is he on ambisome? And they're like, well, because have you seen the CT? And I'm like, I'm looking at the CT. So when I look at this CT, first of all, you can see that this is on the right side, that this is behind the pericardium, because this is the back side of the patient lying on the bench, and that this, to me, is in the shape of a wedge, as is pointed out right there. And so then the question becomes, what do you do next? The story just didn't fit very correctly to me, so I was like, I need my people, aka I need my pulmonologist. So looking at my differential diagnosis, and then I send the patient to pulmonary to prove it. Is this just a pneumonia? Is this a community-acquired pneumonia? He has been in the hospital. Maybe it's hospital-acquired. If it is a pneumonia, is it bacterial, viral, or fungal? Is it a tumor? Because it looks like as if something is being occluded, and it looks more like a post-obstructive pattern. So, or did somebody inhale something? Is there a foreign body there that's causing the obstruction? or my favorite other word, other. So for CAP, HAP, working this up, tumor, foreign body, essentially I need to get a lavage and biopsy. It's always tissue is the issue. It never will go away. So they did a bronch, and then what did they find? So first we had a CT at the outside hospital that had pleural effusion. So we did a bronch, or they did a bronch, it was negative. They did another bronch, it was also negative. He went on VORI because they're like, this must be mold. That's why it's not growing. And then the CT was like post-obstructive. We did a biopsy. We got a different procedure, which is navigational bronchoscopy, which is available where I am. And they definitely saw something in the bronchus. They took off a bit and it didn't grow anything. We looked at it under the with pathology, and it showed atypical squamous metaplasia and necrosis. We did another bronch, it was negative, and then this time when they went to go take another piece of the pathology, the lesion was gone. That essentially was kind of like a scar in the endobronchus that then it just kind of crumbled and went away. But you can see this poor gentleman, he had a number of different procedures done just because of this issue. So the good thing is, though this was his original CT from May, that when we finally essentially broke off by bits of parts of this endobronchial lesion, that we opened up the airway, and then by himself he was able to kind of resorb the post-obstructive changes. Obviously I also stopped the ambisome because I didn't need it, and then he got better. So I told him no voriconazole, no ambisome, that this was a physical issue, and that I appreciated my pulmonology help with their navigational bronchoscopies. And that he was able to move forward for his allo transplant. So kind of coming back full circle, the goals and objectives. So that first case, we talked about this horrific workup for FUO, and not to underestimate the possibility of a rickettsial infection via blood products. All else fails, try some doxy, try to get your patient to become afebrile, feel better, and get discharged. The second case is not to forget that our epidemiology is changing. Whether it be from climate change, because people travel so much, it does not matter. The reality is dengue is here. Be able to tell the difference between dengue fever and chikungunya fever. Number 3, be very careful about cases that come to you from other hospitals. They have kind of this perception of what it is. You have to look at it open-minded and not with premature closure. I could tell that the pattern was not typical for fungal pneumonia. Fungal pneumonia is traditionally nodular in presentation, with ground glass, with a halo or reverse halo, but not in a wedge formation. So then you call your best procedurist to get them to help you to make a good diagnosis. And then you ultimately figured out it was a post-obstructive pneumonia from an endobronchial scar that ultimately resolved. And then you removed the drugs that were prematurely given to him for a different diagnosis that, realistically he did not have. I just wanted to say thank you for your time, and that also remember there are specific infections based on geography, that be aware when there are warnings that go out from the state. And then in terms of references, remember there are free guidelines on the IDSA website. There are the ASCO guidelines. The Stanford guide is fantastic. The same price for the app that's continuously upgraded compared to the book. NCCN guidelines as well, and Lexicom is very good, especially for drug-drug interactions. And that if you're listening to this, you're already cognizant of ID podcasts, but continue to share that information with others. As always, I like to give a shout out to my team. It definitely takes a village to be smart. That is infection prevention, ID pharmacy, ID clinicians of the doctor variety, the APP variety, the nursing variety, and of course, we stand on the shoulders of giants being the microbiology lab. I also want to give a shout out that for me, I get to work transplants, so to remember our BMT people, that without them, we wouldn't be able to give fantastic care to our patients. And thank you very much.